Hi, I'm Jennifer Anders. I am Maryland's Associate State Medical Director for Pediatrics. In the 2025 Maryland Medical Protocols for EMS, you will find two changes in primarily pediatric patients. One in the treatment of narrow complex tachycardias, and the other in the intraosseous infusion procedure. In this module, we'll review both those changes and see how they fit with our existing practices. First, let's zero in on the pediatric tachycardia algorithm. In the past, a medical consultation was required prior to cardioversion of an unstable, wide complex tachycardia. However, no consultation was needed for cardioversion of the corresponding narrow complex tachycardia. To ensure consistency and avoid confusion, a medical consultation is now required for cardioversion of narrow complex tachycardia as well as wide complex tachycardia in pediatric patients. In reality, there is a low incidence of pediatric tachycardia requiring cardioversion in the pre-hospital setting. As the need for pediatric cardioversion is not encountered frequently, a consultation can help ensure the best treatment for the young patient. You are treating a 7-month-old female patient who is pale and lethargic. Her mother reports that she called 911 because the infant is sweaty, breathing rapidly, and refusing to eat. On your assessment, you find that her heart rate is 240 beats per minute, and you see a narrow complex tachycardia on the cardiac monitor. It appears to be supraventricular tachycardia, or SVT. Vagal maneuvers and adenosine administration fail to convert the rhythm out of SVT. You're now considering cardioversion. A medical consultation is required prior to cardioversion. True or false? The correct answer is A, true. For pediatric patients, a medical consultation is required before attempting cardioversion of a narrow complex tachycardia. Now we turn to the intraosseous infusion procedure. Here we find that the entire procedure has been streamlined and a new insertion site, the distal femur, has been added for pediatric patients, those that are less than 13 years of age. Let's take a closer look at the procedure first, and then we'll discuss the landmarks and technique you'll use for insertion of an IO in the distal femur. Note that the indications have been simplified. An intraosseous line is indicated. In cardiac arrest, IO is indicated for adult patients who do not have an apparent or available IV site, while for pediatric patients, you may go directly to an IO in all cardiac arrest situations. For patients with other life-threatening illnesses or an injury requiring immediate pharmacologic or volume intervention, IO should be used if there is no available vascular access or if there have been 2 unsuccessful peripheral IV attempts and the patient has an urgent need. There are several contraindications remaining for intraosseous lines. They should not be used in those conscious patients that have stable vital signs, or in other patients that have readily available vascular access using a standard IV. The IO should not be used when there's a suspected or a known fracture in the extremity targeted for the IO insertion, and they should not be used if a previous IO attempt has been made in the same bone within the last 48 hours. The IO should be avoided if there is cellulitis or some obvious infection at the intended site of the procedure, and they should not be used in patients with a known bone disorder. Should be avoided in patients that have prior knee or shoulder joint replacement in the targeted extremity, and if there's an inability to identify the appropriate landmarks for placement. The potential adverse effects and precautions around intraosseous placement are unchanged in the protocols. You'll notice that the preferred placement sites for each age group have been consolidated into a table to make this easier to read. For patients that are greater than or equal to 13 years of age, adults and large teenagers, the proximal humerus is the preferred site for mechanical IO placement. The proximal tibia, just below the knee, is the second choice, and the distal tibia, down near the ankle, is the third choice for mechanical IO placement, but is a preferred site for manual insertion. The distal femur site has not been approved for patients who are 13 years and older. For pediatric patients less than 13 years of age, the proximal tibia remains the preferred site for both mechanical and manual insertion. But the new distal femur site is a second choice. The third option is the distal tibia, and a fourth option is the proximal humerus, which should rarely be used in pediatric patients. For neonates, those infants that are less than 3 kilograms, IO can be attempted by a manual insertion with an 18-gauge intraosseous needle as the only allowable technique. The preferred site for these tiny babies is the proximal tibia just below the knee, and the second choice is the distal femur just above the knee. Remember that 2 attempts within 5 minutes are permitted, and if additional attempts are required, medical consultation should be sought prior to those attempts. If there's pain when an infusion is started via the intraosseous line, it can be treated with lidocaine. There is age-based dosing for that lidocaine outlined in the provided chart. You might notice that administration of lidocaine was previously contraindicated for patients less than 5 years old, but is now permitted with medical consultation. So let's review the new site for intraosseous placement. While the primary site for pediatric patients under 13 years of age remains the proximal tibia, shortly under the knee, the nearby alternative site is the distal femur, just above the knee. Both these locations are approached from the medial side, so the inside of the leg. You might remember that the distal tibia is located by feeling for the tibial tuberosity and then going 1 to 2 finger breadths below on the medial side of the tibia. The placement of the distal femur is very similar. We feel for the top of the kneecap, the patella, and then go 1 to 2 fingers above the kneecap to the medial side of the femur. We'll take the appropriate size intraosseous needle attached to our mechanical device, and we can test whether that is the correct size by pushing through the soft tissue until we feel our needle touch bone. There should still be at least one black line visible above the level of the skin. That means we have enough space, enough length of the needle, that as it goes through the cortex of the bone, it will be able to reach all the way into the center of the bone where the intraosseous infusion can be absorbed. So we push down, we locate and make sure that our black line is visible, and then with very gentle pressure, we drill until we pop through the cortex of the bone. From there, we would hold it in place, take out the stylet. We can attach our device to hold it in place and secure our infusion set. A properly placed IO will be firmly placed, not wiggling in the bone. You may or may not be able to withdraw any blood or bone marrow with a syringe, but you should notice that as you infuse through the IO, no fluid collection or tightness develops around the site. If you notice any of those signs that the IO is not in a proper placement, you can proceed to a new site and try again. A 5-year-old boy is in cardiac arrest. High-performance CPR is underway and the cardiac monitor is attached. Prior to intraosseous insertion, you must first attempt peripheral IV access. True or false? If you answered B, false, you are correct. For pediatric patients in cardiac arrest, don't attempt peripheral IV access. Go directly to an IO. The proximal tibia site is the preferred site for IO placement in patients less than 13 years of age. If the proximal tibia is unavailable in this patient, your second choice would be A, proximal humerus, B, distal tibia, or C, distal femur, D, proximal femur. The correct answer is C, distal femur. In conclusion, thank you for the excellent care you take of children across Maryland every day. Remember, every child deserves safe transport. That may mean using a pediatric adaptation on a regular stretcher. That may mean using an approved child safety seat. It should never be a child transported in their parents' arms. It is unsafe for both the child, the parent, and for you inside that ambulance.